Welcome to Don't Be Rash, the pediatric dermatology show, the owner's manual for your kid's skin, and the official podcast for the Society for Pediatric Dermatology. I'm your host, Dr. K, board certified pediatric dermatologist and father of two boys myself. Today's episode is going to be dedicated to getting an update on the management, mostly procedural, of a particular birthmark known as Port Wine Capillary Malformation, previously known as Port Wine Birthmark, previously known as Port Wine Stain, previously known as Nevus Flammis. Alas, what's in a name? And to help me get to the bottom of that very question is my West Coast colleague, Dr. Kristen Kelly, laser surgeon extraordinaire and chair at the University of California, Irvine. Dr. Kelly is one of the good ones. And I mean, more than just being a great colleague, she is a great human being. She's done amazing things for pediatric dermatology and for her patients. Welcome, Dr. Kelly. So nice to have you.
Well, it's very nice to be here. Thank you for that kind introduction, and I'm very pleased, and I look forward to our discussion.
Me as well. I always learn something when I'm speaking with you, and I usually just try to shut my mouth and do the listening, which is sometimes hard for me, but not in your presence. So I'm sure we will get a lot out of this conversation. So why don't you start simply by explaining to the audience what it is we're talking about when we're saying port wine capillary malformation, why that very specific phrase has been selected, what are these things physically, why are they special, and why do we care?
You gave a very nice introduction with kind of the evolution of the name change, and that's kind of perhaps a good place to start. So these port wine capillary malformations, which is the preferred term at this time, are red spots on the skin. Now, there are lots of different red spots that can be on the skin, but these particular ones are present from birth, and they result from a genetic change that causes the individual to have extra blood vessels in that area. For a long time, we thought those blood vessels were completely normal, or at least that they acted relatively normal, although were larger. But over time, we have found that, again, they have this genetic change, and that we are trying to learn about what that genetic change exactly causes in these blood vessels to make them have sometimes more vessels and to have larger vessels. And that is what gives the red appearance in the skin. I say red appearance, but it can vary a little bit. They can be light pink, red, or purple. Often when an individual is born, they're relatively flat, but they can over time, and when I say over time, I mean decades, develop nodules, and you can get thickening of certain parts of the skin, or even enlargement of the structure underneath, which, for example, like on a face, could be enlargement of the lip area on that side, or for an extremity can be enlargement of the either arm or leg on that side.
And I think it's really important. You sort of alluded to it. While it looks flat on the skin, these things are living three-dimensional lesions.
Yes, and very good point. And so, each one is one of the interesting things is that they are very individualized. And some people have more vessels in their port wine capillary malformation than others. And some of them are not very deep, and then others can be significantly deeper. And that can also change over time. So initially, probably most of them are relatively superficial, but in some individuals over time, as I was mentioning, they can thicken. We initially called them port wine stains. Dermatologists sometimes like to name things with food kind of analogy. We have a number of examples, and I guess this would be another one.
Yeah.
But a couple of years ago, in doing a study with the Sturge Weber Foundation, we found that some individuals with these lesions found the word stain to be derogatory and made them feel bad. And actually, it was really enlightening for me, because certainly I never intend to make anyone feel badly. And so, hearing that made me quite sad that perhaps I had contributed to someone feeling uncomfortable. So we really promoted, as did many other people, using the term birthmark instead, which is fair because they are birthmarks. They are present from birth. There are rare acquired cases, which are probably slightly different, but can look very similar. But recently, the International Society for the Study of Vascular Anomalies met, and they kind of reclassified things. And this was one of the areas that they reclassified. And the term port wine capillary malformation is the preferred term. It still has the port wine, which kind of describes what it looks like, but is more descriptive in that, again, these are capillary type vessels, which are small vessels, and then they're malformed. So there's this genetic change that makes them different from other vessels.
Yeah, there's something about the newest naming iteration that I like because somehow in my mind, and maybe I'm connecting the dots farther than I should, but I feel like port wine capillary malformation sort of speaks to the underlying pathophysiology a little bit more than some of the other previous names, and maybe even um, give some insight in terms of how you would go about treating these things, which is what today's episode's totally on. What is the gold standard for treating a port wine birthmark in your clinic?
So currently, the gold standard, I think probably in most of the world, is a pulse dye laser. This is a laser that's been around for a long time and has a very good safety record. This does not mean that one couldn't have an injury with it, but used properly, generally can be used quite safely and has been used now for decades to treat these with good improvement. But it takes multiple treatments, and not everyone gets as much improvement as they would like.
Off off the cuff or from the hip, what is your sort of go-to spiel when you're talking to a patient or a patient's family of like what should they expect? How many treatments to get? How clear? Do you have a canned prepped talk that you like to discuss?
Yes, and a couple things. One, and I'll just stay here because I think it's an important point, is we do like to try to treat patients as early as possible. And when I
Mhm.
say as early as possible, if we can in the first week of life, that would be the ideal scenario. Because we can treat patients early safely. That's has been known for quite a long time that we can treat very young children safely. And there is evidence that we may get a better result if we start early. That if we treat with a number of treatments in the first couple weeks to months of life, that we are going to get a better result so that hopefully by a year of age, I wouldn't say most of them are 100% gone, but you have a higher chance of getting 90% or more resolution or improvement by the time that a child is 1 year of age.
And what are some of the factors that go into, I mean, sure, it just intuitively sounds like it might make sense. Treating a baby earlier in life might give you a better improvement, but also might increase your unintended consequences, side effects. But we think we have a couple reasons why it might be useful to get to that child as early as possible. Do you want to share that a little bit?
Yes. So there are a couple of different factors. One is that infants have something called hemoglobin F, so fetal hemoglobin, which you only have for the first couple weeks to months of life, and then it goes away. So it's kind of like an extra target that we have that the laser can go after. So that's, we think, is beneficial. Two, the vessels are a little bit smaller. Now, it's not a complete difference. It's not like you can't have smaller vessels later on, but overall, the vessel size is probably a little bit smaller. And over time, you get more of the large, dilated, uh, really kind of tortuous vessels. And so those can be more difficult to treat. Whereas in a young child, we have fewer or we don't have those. And then also, there is less melanin in the skin in an infant. They haven't had any opportunity for sun exposure or anything like that. And then other factors that contributing to them getting more melanin in time. And that's probably especially important because if a patient is going to ultimately have more melanin in their skin, they have a darker skin type, starting early really gives us an advantage because the melanin absorbs that light energy and it's higher than the blood vessels are. So if the light gets absorbed by the melanin, it doesn't get to the blood vessels where we want it. So the sooner we get the patient when there's less melanin, the better advantage we have in terms of being able to target the blood vessels and less of the melanin above it.
So safety and efficacy rolled up into one there. How about the thickness of the skin with the limitation of, I think when most people hear laser, they think of Star Wars. Geez, we can shoot this thing, through universes and galaxies. What are we talking for a maximum depth of penetration with a pulse dye laser?
Very good point. So the pulse dye laser only goes about a millimeter into the skin, and it's going to be absorbed by those first blood vessels that it encounters. So if in an infant, again, much of the time there's less thickness to the overall lesion, and so that allows us to. And also the skin is probably a little bit thinner overall initially, which also gives us an advantage.
And then I sometimes will just add when I'm speaking with the families that trying to get to the child a little younger, just from a practical perspective, a social perspective, it's probably not necessarily in all cases, but it's probably more acceptable for a 1 or 2 year old to be bruised up because we didn't really mention it, but the laser, one of the often intended consequences of the laser is you're left bruised up after the procedure. It's probably more acceptable for a 1 or 2 year old to be bruised up than a kid who's trying to integrate back into the classroom and not have to answer a bunch of questions that he or she's just not comfortable having to deal with. I don't know that if that comes up much, but it's certainly in the back of my mind.
I think it's a very important point. And also, as an infant, yes, you might have someone who may say something, but once a child is going to school by themselves, it's probably, one of their classmates or something might say something. So if we can remove it before they're going to school and then they're in a situation alone where a classmate might ask them, or hopefully not, but might make fun of them or something like that, and we can help them avoid that, then that's a benefit as well.
So let's say you have the ideal patient, ideal age, ideal skin thickness, ideal melanin type. Um, what is your expectation for in your hands, your expert hands, Dr. Kelly? What are you suggesting to the family that they should expect after X number of treatments?
So truthfully, I always tell patients that, the longer I've done this, and I've now done this for about 30 years, that what I learn is I can't always predict this. As much as I would like to say, okay, I can do 10 treatments and then I know this is going to be gone, port wine
Mhm.
capillary malformations are variable. And so sometimes you have a lesion in a patient with not very much melanin, but then like a light pink lesion, you might think, oh, this is probably going to be an easier one, but it can be more difficult. And so we
Yeah.
can't always predict. But once I start the treatments, I can often get a sense because
Mhm.
ones, for example, now you often don't get bruising in very young infants. You mentioned we get bruising, and we do get bruising, but for some interesting reason, which I don't know yet, in very young infants, we see less bruising, although they do get improvement.
Mhm.
And so, after a couple treatments, if I'm starting to see improvement, it gives me a positive indication that likely we're going to have a good effect. If I'm not seeing anything, that might tell us something and there are a variety of reasons that can happen. It might be the size or depth of the vessels, although, as we discussed early on, that's probably less of a factor. It could be the amount of flow that's going through the blood vessels. Some of them we
Mhm.
think might have a little higher flow, and those might be more difficult. Or there might be other factors which truthfully, we don't know yet.
How much does anatomic location of the birthmark itself affect? Are all birthmarks equal?
No, that's a very good point. Face lesions tend to be a little bit easier to treat for the most part. Now, again, that's not 100% because sometimes we have some facial lesions which are difficult and we don't always know why. Lateral face tends to do a little bit better than central face. For
Mhm.
example, the lip is often a more difficult area, and we don't totally understand that either. Extremities can be more difficult, although once in a while I'll have an extremity lesion that just goes away very nicely.
Yeah.
But that's not always true. And I think overall extremity lesions can be more difficult. And I think legs are more difficult than arms for the most part.
And then we have to deal with this phenomenon of revascularization, remembering that these birthmarks are living organisms, sort of, obviously they're not by themselves living, but they have a life cycle about, and they want to continue to exist. How does that factor into your treatment?
Another very good point. Stuart Nelson, who has been a mentor to me over my career and also a colleague now at the Beckman Laser Institute, he describes it, and I like the way he describes it, is that, the laser does what it's supposed to do, which is to break those blood vessels or cause clots in those blood vessels so we can help them to go away. But then the body does what it's supposed to do, which is to heal. And so we make some of those blood vessels go away, or we break them, and then or we cause a clot in them so that there's no flow and then they'll go away. But then the body comes in, it does a healing process, and new vessels come in. One of the things that I think is a factor here is that because we do know that some of those endothelial cells, which are the cells that line the blood vessels, have this genetic change, that if we don't get rid of all of those, the genetic change is still in those cells. And so that drives for some of those cells to come back and for some of those blood vessels that are different to come back as well.
And I think that's a great segue because a lot of what you've lectured on at the conferences I've seen you, a lot of the articles that I've seen you publish, you talk about a particular pathway that was probably worth talking a little bit about and just naming, because I think one of the interesting questions is how you might take advantage of some of the non-laser approaches to help knock out that pathway or at least improve our outcomes.
Yes, and that, so for a while we know that the most common genetic change, and there are multiple that can happen, but the most common change is a GNAQ mutation. This is a G protein that there's a change in it, so that there is a mutation that then makes again these more of these blood vessels, and that they become more tortuous and in some cases larger. One of the things that people have tried is to try to determine really the pathway. And we do think that we have some ideas, although I have to say that as new research has gone on, we probably are determining that there might be other factors that we weren't thinking about before. So again, this is kind of our current thoughts, but I do think that we're going to have more and perhaps even better ideas as time goes on.
Okay.
But
That sounds like a little hint of something that might be on the horizon. That's great. Okay.
So, as you mentioned, people have tried things. For example, rapamycin has been tried, so that is an mTOR inhibitor. And so, that is one thought. And we did get a little bit of improvement compared to just doing the laser alone, but truthfully, it was not as beneficial as we had hoped. And so the question is, why is that? Is that the right pathway, or is it just not the right position in the pathway? And so that is something that's still being looked at. People have tried other things like MEK inhibitors, et cetera, and I think there's still work ongoing on that. But again, I don't think anyone right now, there is not a good medication that's treats these. And so clearly we don't have the exact right information, but there are a lot of very smart people working on this across the country. And I feel pretty confident in the next couple of years that we'll know more about the pathway and be able to target it better.
So obviously the workhorse is the pulse dye laser. We've talked about that. There are a couple other lasers that we might use in this sort of treatment approach, treatment ladder, especially when these port wine birthmarks, capillary malformations start to thicken, as you mentioned, that they tend to do, and develop the blebs. What lasers are you considering, and what's your sort of take on utilizing these other modalities?
So the pulse dye laser is definitely my favorite laser. And the reason I like it is we've already discussed this a little bit, is it has good efficacy and it also is a pretty safe laser. Honestly, I use that 99% of the time. And especially in children, because as we discussed, for the most part, there's limited thickening, if any at all. And so really the pulse dye laser should be able to help us. If I feel I need to go a little bit deeper, for the most part, then I would do a second pass, which helps you to go a little bit deeper, as opposed to moving to another device. I do think it's reasonable to note that I think a long pulse 532 nanometer laser can also get a very good result. Our group has done some of this. Katharina Herberger from Germany has also shown this very nicely, that probably those two devices can be equally good. And some people think the long pulse 532 can be even better.
And
So,
that would be a laser. Again, we're mostly a group of pediatric dermatologists, so I would say almost as a default, if you had one laser, and some people might not even have that, but they would have this pulse dye laser, which by the way costs upwards of $150,000. These is like having a Ferrari. And they break down and need a service contract too. That's $20,000 to $30,000 a year. So these are not inexpensive toys. The 532 would be a laser that you might expect to see in like a cosmetic practice, probably more than necessarily a pediatric dermatology practice. Is that fair?
Sometimes, yes, although I would say that, in certain parts of the world, for example, in Europe, some people might have a long pulse 532 instead of a pulse dye laser, and I think it
Really?
would be a
Okay.
perfectly reasonable option. The third option that I would mention that I think is probably the next most common would be intense pulse light. I feel that I think that's a little bit less effective than the pulse dye laser or long pulse 532. But if someone only had that, I think it's a reasonable option. And there were times when some people felt that it was equally efficacious, but I think it's probably a little bit less efficacious than the pulse dye laser.
Mhm.
Now, in terms of going deeper, you mentioned that, sometimes we'd use some additional devices. You can use a long pulse 755 nanometer laser or a long pulse 1064 nanometer ND-YAG laser. Those are both choices. But I pretty much never use those in children because again, those are going to help you do is to go deeper. And for children that really should not need to happen for treatment of these lesions. In adults who have thicker lesions or nodules, I might consider it. But again, my preferred way of doing it is to do multiple passes, which allows me to go a little bit deeper with the pulse laser. But there are times I'll treat nodules or something like that with one of the deeper penetrating lasers.
Have you ever approached a port wine capillary malformation with either a fractional or fully ablative CO2 or similar device?
So I don't use that as my first line treatment, but sometimes patients have had many treatments, sometimes at different places, and sometimes they've had scarring that resulted from other treatments, et cetera. Hopefully not a treatment we've done. We try to be very careful so that's not the case. But if a patient does have some scarring, sometimes I'll do an ablative fractional laser in the same kind of settings that I would for a scar. You do the pulse dye laser first, and then you can do the ablative fractional. Again, kind of like how you would approach a scar, and you can treat that way. One
Mhm.
thing I didn't mention about the long pulsed Nd:YAG, but I do really want to emphasize, is one of the main reasons I don't use it very often. One is that sometimes you don't need to go deep, but even if you do want to go deeper, it has a much narrower window of safety. There
Mhm.
is not a good endpoint. It really goes more after arterial blood as opposed to venous blood. So oxygenated blood versus deoxygenated blood, which the vessels for these lesions tend to be the deoxygenated one. And because it goes deep and it's less specific for blood, you have to use very high energies. So there is a narrow window of safety, and it is very easy to cause a scar with that device.
With the Nd:YAG.
With the Nd:YAG, the long pulse. So, and to clarify, the long pulse 1064 Nd:YAG.
Right. It's interesting. I remember very distinctly Vic Ross in San Diego saying at a lecture in regards to the Alex, the 755, if you have not scarred someone with the Alex, you haven't used it enough. And I thought, geez, I don't want to get that good at that.
Yeah,
It's just something I don't
exactly.
want to be known for utilizing on a frequent basis. So I sort of am very, very aligned with you in terms of not using those lasers unless I really have to, and it's almost never really. So,
I agree.
well, one thing that I think we can talk about in generalities is maybe a new approach for treating these port wine capillary malformations, not so much from the outside in, but dare I say from the inside out or inside out back to in. I don't know. But
Are you talking about photodynamic therapy?
yes, I was
Yeah.
hoping you might bring that up. So you want to share how that kind of works and what the theory is behind it?
So photodynamic therapy is something that's used, I would say, I think more commonly, if not maybe even commonly in China, but really has not been used in other parts of the world. It's been used for quite a number of years there. It involves delivering a photosensitizer. Now, dermatologists are used to doing photodynamic therapy, but we're usually used to using a topical cream that we apply. We wait a period of time and then we shine a light on the area. And it's the combination of the medication and the light that creates reactive oxygen species that causes an effect. Now, if we want to treat blood vessels, we can't apply the cream to the top because it doesn't get selectively to the blood vessels. So what we have to do is give the medicine intravenously. And then for you have a short window of time when the medicine is only in the photosensitizer is only in the blood vessels. And during that time, then if you shine the light on the area of the port wine capillary malformation, then you can get the effect there. And again, the way it works is by the combination of the photosensitizer and the light creating reactive oxygen species, which then damages the vessel's walls. And then similar to the laser, the damage to the vessel wall will help it to improve.
Pretty amazing in theory.
Yes, there are some definite advantages because we talked about melanin before. And so this really doesn't rely on melanin because or melanin doesn't block the light from getting where we need with this. And so we can treat all patients of all skin types, which is a definite advantage. There are disadvantages, though, is that, with lasers, we often have endpoints that help us to use them more safely. We talked about the long pulse Nd:YAG doesn't have a good endpoint, but with the pulse dye laser, we have some good endpoints. But with photodynamic therapy, there is less of a good endpoint while you're doing this. So it's often done by a period of time. And We do have to give the systemic photosensitizer, which means the entire body is sensitive to light for, depending on which photosensitizer you use, from most commonly a week to 2 weeks. Some photosensitizers are a little shorter, but that means someone needs to stay in their house away from light for that period of time, which you can imagine is not all that practical for many people. Can't go to
Right.
school, you can't go to work. But there are studies that show that you might be able to do a significantly smaller number of treatments instead of 10, 20 or more treatments with our pulsed dye laser. Maybe you can achieve a good effect, at least in some patients, in 2, 3, 4, 5 treatments.
How would you rate overall sort of the pain involved in that procedure versus an individual laser session with the basic pulse dye laser?
I do think there is more pain that can be associated with it. It starts kind of low with the photodynamic therapy, but then, that while you're shining the light on it over a period of time, the heat intensifies. And so you can do things like spray water on it, et cetera, to try to help a little bit, but it is uncomfortable. And the person has to stay still, because you're shining a light on a particular area. And if you shift the light to another area, that area is going to be damaged, even if it's outside of where the port wine capillary malformation is. So you really have to have the person sit still. You can imagine for an adult, that's easier to do, but for a young child, especially an infant, very difficult.
But this has, I mean, to be fair to the technology, it has been utilized since, geez, I remember reading an article back in like 2015, 2016 in an American journal. So presumably even longer than that. But it remains to be seen if and when it will take a firm hold in terms of our treatment ladder here for port wine capillary malformations. We have the great benefit of having you just attended the ASLMS conference in Savannah, if I'm not mistaken. Is that correct?
Yes.
Did you have any great hallway conversations that you might be able to share with us as it relates to the treatment of port wine capillary malformations?
I do love that meeting because it allows people, from all over the country and truthfully all over the world to come and, kind of discuss their experience. We talked about some of the things that we talked about today, uh, photodynamic therapy, will we be able to have a photosensitizer here in the United States? What are the pros and cons of that? Uh, I think also people like Roy Geronimus, who has been treating port wine capillary malformations for decades and has really been a pioneer in some of the approaches. We are all treating patients earlier. He is trying to do treatments have very little time between those early treatments. So, initially we were doing kind of 4 or 6 weeks. He kind of moved it to weekly. And then now he's even talking in some cases, maybe could you do a couple treatments daily, very early on, and then have clearance maybe even by a couple weeks old. So that's new information that needs to be looked at further, but it's something that he's been looking at, trying to get the treatments earlier and earlier.
He would probably, if he could, maybe team up with maternal fetal medicine and handle some things in utero. But
I agree. Yep.
how about you've published about it, you've talked about, how about some of the technologies that might improve our ability to not necessarily treat the port wine birthmarks, but to understand how well our treatments are working and better maybe delineate where the birthmark starts and stops and allows us to sort of get a better handle on it.
So we talked about a lot of things that we don't know. I mean, we talked about things we do know today, but we talked a lot of things that we don't know. Like why don't some of the capillary malformations, why don't they respond as well? Why do some of them progress with time and then others don't? And so, we've been doing a lot of work using optical coherence tomography. I think of it as kind of like an ultrasound that we can do on the skin, but gives us information without doing a biopsy or anything invasive about the size of the vessels that are there, a little bit about the depth of the vessels. It doesn't usually go to the full depth of the vessels, but it can give us some idea about where the vessels are most dense. The density of the vessels in one capillary malformation compared to another, or even from one spot in the capillary malformation compared to another. And so we're really trying to get this information. We've looked at different body parts. We've looked at different colors with the capillary malformation. The interesting thing is, the one thing that stands out is there's a lot of variability, and that even from spot to spot within a capillary malformation, there's variability, but Although there are some general things, it's not that all leg port wine capillary malformations are the same. It's not that all, ones in certain areas of the face are the same. So there's just a lot of variability. But we are hopeful that with time we'll maybe be able to determine the genetic change without having to do a biopsy, and that we can have other important information that will both guide our treatment and then help us predict who's going to respond.
That's amazing. Good time to be involved in port wine capillary malformations. As we sort of wrap up, I was hoping that you might speak. It's not often that we're speaking with a chair of a major dermatology department outside of pediatric dermatology. I was hoping you might shed a little light, not necessarily energy or laser, I should say, but just if you could shed a little light on some of the groups, the organizations, maybe it's the SPD, maybe it's Sturge Weber Foundation that have had an impact in your career and the value of mentorship, what that's meant to you.
So I think that's a really important point, and I'm so glad you brought it up. I have been very fortunate through my career to be able to involved with a number of organizations that both seeks to help give more physician information or information to the physicians, but also helps to connect families with each other and then with physicians who have expertise. That would include the Sturge Weber Foundation and the Vascular Birthmark Foundation. They're both fantastic groups. They have great leaders who have really done a tremendous amount in terms of getting knowledge out, guiding treatment guidelines, and helping also to promote research so that we're able to treat these better. Also, I've been very fortunate throughout my career to be able to work with a variety of students and residents, and then some over time have gone on to fellowships and things like that, and then are out treating patients now. So it's one of the things I greatly enjoy. I hope that I've been able to provide a little bit of knowledge to some of them and that they're able to help other people. Of course, that's the goal overall, is to be able to try to help people. And then the more people you teach, hopefully you're able to get to more people.
Well, you certainly more so than most have accomplished that, and it's amazing to have you on the show and learn from you. It's always a pleasure. Just I could listen to you all day, and I know it was not easy to finish a work day and hop on for a podcast, but much appreciated. Always great to see you. Well, thank you so much again, Dr. Kelly, for joining us all the way from California. As usual, just a total pleasure to have you with us. Always a pleasure to learn from you. I could listen to you all day. With that, thanks for tuning in to this episode of Don't Be Rash, the Pediatric Dermatology Show, official podcast for the Society for Pediatric Dermatology. I'm your host, Dr. Andrew Krakowski. Don't forget to subscribe to our show on your favorite podcast platform. Check out don'tberash.org for more information. Of course, a special thank you is due to our nonprofit sponsor, the Society for Pediatric Dermatology, for making all of this possible. Please make sure to check out pedsderm.net to find a pediatric dermatologist near you and to access all of the amazing science-supported, fact-based resources that the organization offers, both its members and the public at large. Until next time, remember, keep calm and don't be rash.